We are back with another episode of Curbside with the Doctor. So the past 6 or 7 weeks, I think, I have been shadowing and observing an orthopedic spine surgeon here in Arizona. And the last 3 weeks I've actually been scrubbing in on the procedures and things like that. And I wanted to talk about just a few of the things that I have noticed, seen, realized in my time. And so, first off, I want to say the reason that I am doing this is because the way that I learn how to be better at the craft that I do, which is the injection therapies, right? Taking a needle and putting it into a location, is by looking at the anatomy, the approaches, techniques from many different angles. And so in the injection space, I'm a big believer and proponent for having students and other docs, including myself, having an understanding of how do we do these injections palpation guided, so based off landmark techniques. How do we do these injections with ultrasound? How do we do them with fluoroscopy? Because understanding the anatomy and the approaches in all three of those helps to really build a strong conceptual anatomical model in your head that you can revert back to when you're doing these procedures, which will allow you to perform them better, but also if a complication arises, allow you to better address that complication because you again have this better understanding. And so I had the opportunity to spend some time with this orthopedic surgeon, and he specifically specializes in spine, which is one of the main areas that I have really started to subspecialize and focus in the injection space. And again, my ultimate goal was to have a better understanding of how these surgeries are performed. So that way, one, I have a better anatomical understanding when I go to do my procedures, but also, what if somebody has a procedure and they have a long-term chronic pain from that procedure? Or what if they have this procedure and it didn't fully resolve their pain and they're now coming to me? What changes do I have to make based on what was done in that surgery? And those things are really critical to understand. And so some of the, aside from like the approaches, the anatomy and all that stuff that I'm learning, which has been just mind-blowing, the big things that I have really realized being in that space is we have to be careful to not let the pendulum swing too far. There is a time and a place for surgery. There are people in the world who they need surgery in order to help with their severe herniation that is, and disc degeneration that is so far gone that it is to the point where, it might be an 80-year-old lady and she is now at a fall risk. And if she falls and fractures a hip, that's not good. When you fall and break a hip as an elderly patient, that is almost a death sentence, and that's terrible. And so there's definitely a time and a place for surgery, and I think too many people forget that, especially in the regenerative medicine space. It's all just, nope, there's, surgery is the devil, it's terrible, it's evil. And, talking with these patients and seeing some of their lives completely transformed because they were that far gone is just a good, humbling reminder that there is a time and a place for surgery. Now, on the other side of the spectrum, I think it's really important to have an understanding that not everybody who goes through surgery is truly at the place where, they are so far gone and at wit's end in terms of that example that I just gave with, an elderly lady and a fall risk, and so it's important to operate on her so she doesn't fall and break a hip. There are some patients that, we're doing consults with, and I already in my mind am thinking, okay, if this were my patient, this is how I would approach it and things like that. And I think there are some patients that end up going through surgery who still do well, but maybe never needed surgery in the first place if they had access to different therapies that are not standard in the conventional world. Things like perineural injection therapy, nerve hydrodissections, prolotherapy, PRP, autologous stem cell therapy. And not everybody has access to that. And part of that is due to a financial constraint. But also at the end of the day, with some of the lower tiered therapies that can still be really helpful, things like prolotherapy and perineural injection therapy, those aren't thousands and thousands and thousands of dollars per treatment. But part of the other inaccessibility is that patients don't know these exist because they're not in the conventional standard model. They are not covered by insurance. And so a lot of interventional pain docs, the docs who are going to be doing the injections before they're sent to the surgeon for a surgical consult, they're not doing these because, one, insurance doesn't cover it, and so they're not going to get reimbursed on it. So why would they do something and make $0? And it's not part of that system. And so I think those are probably the biggest things that I've really so far taken away from this wonderful, amazing experience that I've had so far. Obviously, other than the complications, the technical anatomical side of the equation, which greatly helps in my performance and my craft. But we just have to remember that there is a time and a place for surgery, but that's not all the time, nor all the place. And we just have to work together to try and improve the suffering of humans along the way. And if somebody needs surgery, then that's what they end up getting. But my ultimate goal here is to try and help people avoid that surgery if possible, but realistically tell them if I think that they need the surgery. So just some insights for the day from the curbside with the doctor. See you later.